Okay, I think we're ready to start. So, good afternoon, good morning, good evening to everyone on the call. It's a pleasure to be here. I'm Freddie Bray. I'm going to co-chair this meeting with Dr. Karen Cantrell. Actually, Karen's going to do a lot of the work, but we have a very, very busy meeting. So this is one of two consortium calls for the COVID Cancer Global Modelling Consortium, the CCGMC. There's going to be another one, at least in my time, at 8 o'clock tonight in 13 hours time. So this is one of two. So next slide, please, Harry. Okay, so the aims of today's call, really, I must stress this is an updates call. We've got a lot of slides with a lot of interesting, exciting results coming through from the working group. So we're going to focus on the updates on the activities across the findings thus far from the working groups on outcomes, on screening, on preventative activities. There's going to be some opportunities to bring more in within the consortium. There's a few ideas in terms of trying to get more and more people to participate. So Karen's going to go through that. And also really trying to work on the development of a dissemination plan for all our results. There's a lot of things coming through, as you will see. We need to work on the dissemination plan and make it as efficient and effective as possible. And please do use the chat function to log any questions. And because of the time considerations, we only have 1 hour. Probably we might have to come back to you after the call, depending on the time we have. So next, please.
Sorry, Freddie, it's just not working very rapidly. Hang on.
All right, it's going around the world, I guess. Okay, so the agenda today. So yeah, Karen will give her introductions in a moment. An echo as well, but anyway, and then hopefully Richard's on the call. We will find out. He's the chair of the COVID-19 and Cancer Task Force, and this consortium is part of that. He'll give an update on the task force that met earlier in October, and then Karen will go through the details of the current status of the consortium, and then we'll go through all the three working groups, and we have various colleagues from around the world speaking to the activities in the working group. There'll be a little piece, hopefully with Rami, if he's on the call, on knowledge dissemination to finish us off, and then really the plans for the next call, and if there's time, an open discussion. So hopefully we'll have a little bit of time at the end, but let us see. So I think the next slide. Yeah, so we're just going to see if Richard is with us. Is Richard online? Harry, do you know if he's there?
I don't think Richard's online yet, Freddie.
I'm not sure we're going to wait for Rich, given the time constraints. But as I was on the call, the last call was on the 5th of October. I'm not going to go into depth. We'll try and save the time. But I mean, as you know, the work is really a partnership, and it's based on this task force that really is trying to better understand the impact of disruptions in services with respect to the impact on healthcare workers, with respect to the cancer outcomes resulting from disruptions in the delivery of preventative screening and therapeutic interventions. So there's a lot of work going on in the task force. In the last call, and I'm doing this from memory, but I mean, there's a lot going on trying to better understand what's happening with healthcare workers. There's a survey by Chris Booth in Canada. There's some work looking at silver linings, what actually can be changed. There's a working group on that led by Dorothy Long, and also trying to look at the impact of some of the research by Louis Fox. So there's a lot going on. I think Richard will give updates in the future. Of course, we also speak on the modelling consortium on that.
Freddie, just to let you know, sorry to interrupt, but I think Richard has just joined us. Richard, if you wanted to say a few words.
Oh, morning, everybody. Sorry, I'm just a small ward round to get through, first of all. Hello, everyone. Sorry. No, Freddie, carry on. I don't want to interrupt you.
No, please, Richard. I don't want to interrupt you. Go ahead.
No. Please keep going. It's all right. I don't know how far you got through.
I'm just giving an introduction to the last meeting on the 5th of October. If there's any updates you want to give, Richard, feel free. This is a chance.
No, it's just thanks, Freddie. No, it's I mean, the moment everybody's working very hard, and there's obviously quite a few projects ongoing. I think probably the most mature ones are the healthcare worker survey that I know Freddie just mentioned at the moment, and a number of countries are going to be publishing their results, and we should be able to circulate an update on that. There's also a lot of data we're now aware of countries pulling real-time data on the impact of non-pharmaceutical interventions on both diagnostic delays and also changes in treatment. And I think for the modelling groups, I know Karen and I were having a discussion about this. I think that'll be very useful data to see the differential impact across countries, and particularly where we've got natural sort of comparisons and ecosystems. For example, in the UK, the 4 regional devolved health administrations have had very different approaches to non-pharmaceutical interventions and lockdowns after the first major national lockdown. And of course, we're all having second lockdowns as well. So dreadful as it might be to say, it'll also provide another natural experiment to see what the effects of these other lockdowns are, with, again, very different MPIs and messaging. So that data will be coming out, I'm aware, over the next sort of 2 to 3 months. There are a whole load of publications that have already been submitted, I gather, to the Lancet Oncology, BMJ, etc. And there's a piece we'll be sharing. Actually, I think we'll be able to do it today because it's going to come out on Wednesday, looking at a meta-analysis of the impact of delays in treatment across all the different trials, and that'll be coming out in the BMJ. So I think the task force will be able to see that. I'll be able to send that round, Karen. If that's all right, I can send it to you for distribution.
Great, thanks, Richard.
Yeah, and just to say, the last bit will be the research impact as well, and that's a piece of ongoing work, and it's looking to report probably in December as well. So that's all I really have to say. Thank you, Karen.
Brilliant, thank you very much. And yes, we'll be hearing later from Working Group 1, who'll be presenting on some of the analysis of registry data around impact of treatment delays on survival. So I think putting that together with the important systematic review coming out in BMJ tomorrow, we'll be able to really move forward to capture the impacts with modelling. So I'm just going to move on. Thank you very much, Richard and Freddie. I'm just experiencing a significant delay with slide change, so please bear with me. I'm going to give you a 2-minute overview of the current status of the consortium. Just a reminder that we're over 260 participants from many countries and many institutions. And just a reminder as well that we've divided our activity, broadly speaking, into 3 working groups. Working Group 1, direct impact of COVID on cancer outcomes and treatment outcomes. Working Group 2 is about impact on screening and screening recovery strategies. And Working Group 3 is about cancer risk and prevention. So as will become clear as we go through today, you'll see that the working groups have tackled their challenges in very different ways, and just by the nature of the beast, the working groups have started in different areas. Broadly speaking, Working Group 1 has focused on analysing the available data on survival condition by treatment, as you'll hear. In the first instance, Working Group 2 has been able to mobilise to do comparative modelling analysis using existing models of screening, and Working Group 3 is focused on characterising the impact of the crisis on cancer-related behaviours. And just a reminder as well that we're ultimately looking at a whole range of mechanisms by which COVID could impact cancer outcomes, and these are being captured across working groups. But I think one of the themes that I think will emerge today is that more and more some of the impacts will need to actually enable cross-group collaboration. So we're already talking, for example, in key areas about how to connect some of the work on the impact of the disruption on screening with the impact on treatment outcomes for key cancer types, and to make sure that we can capture the joint effects of these disruptions. And just very quickly as well, this is a timeline of our activities. We formed at the beginning of the crisis in March and April. It was May that we had our first whole of consortium call. And since that time, you'll see a whole range of activities really around the specific working groups, and within working groups, actually project team meetings that have been held. And this is our second consortium-wide call. And as Freddie says, unfortunately, we're going to have to focus mainly on giving each other an update today, but please do log in the chat if you have issues that you want reflected in future working group discussions. Now, we already have a range of publications in preparation. This is just a summary. The steering group is working on an editorial piece about the rationale and aims of the consortium. We're also working on a protocol paper, which will target at BMJ Open, and we'll be keeping participants informed by the mailing lists about these pieces of work. We've also been invited to do an overview of screening impact across screening programs by preventative medicine. We have various outputs coming through from the working groups, and they'll talk to these in detail. But for example, international survival and treatment analyses, systematic reviews that are in process on COVID risk and mortality with people with cancer diagnosis, the screening analyses that are underway from the colorectal cervical groups, and for prevention, and international systematic review of smoking behaviour change in the crisis. And just finally, to finish my update, really importantly, one of our affiliates, the HPV Prevention and Control Board, based at the University of Antwerp in Belgium, is kindly partnering with us to run a major session, an expert technical group meeting about the impact of COVID on cervical cancer screening, treatment and vaccination. And this will be a really important way for us to connect with a range of experts in the field and help to set up the questions that are important for modelling for that particular project team. So I'm now going to move to the working groups themselves, and we'll go first of all to working group 1, treatment outcomes. So we'll be handing over to Isabel in a minute to present on her analysis, but just again, broadly speaking, this working group has progressed analysis in several areas: international survival analysis, systematic reviews and modelling. So I'm going to hand over now to Isabel, hopefully to talk us through the survival analysis results. Thank you. So I think we're now going to hand over to Chelsea from the team at Cancer Council to talk to the systematic review activities.
Thanks, Karen. Hi, everyone. My name's Chelsea. I'm a systematic reviewer at Cancer Council New South Wales, and I'm going to be providing a brief update about the 2 systematic reviews we have underway. So as Isabel was just alluding to with the data, it's been suggested that people with cancer may be at a greater risk of COVID-19 and its complications. And we found, particularly in the early studies, there were a number of methodological issues making it difficult to assess the effects of cancer on COVID outcomes. So we aim to systematically review the evidence as to whether cancer affects COVID outcomes. And unlike other planned or published systematic reviews on the topic, we will assess the methodological issues and potential sources of bias using a tool specifically designed for exposure studies, and then see how these impact the results. So the first review looks at whether people with cancer are at an increased risk of being diagnosed with COVID-19. Next slide, please. And the second review looks at whether for people with COVID-19, does also having cancer increase the risk of death? And results for these reviews should be available early next year. Thank you.
Thanks very much, Chelsea. So now I think we're going to have Jae-Bin Liu speak on the modelling for working group 1.
Thank you, Karen. Hello, everyone. I'm Jae-Bin. I'm a research fellow at Cancer Council New South Wales. I'm going to give a brief update on the plan modelling analysis for Working Group 1. The group are working on developing tools for modeling analysis to quantify the impact of cancer treatment disruptions due to COVID-19. We are planning for a global level analysis as well as country level analysis that use a more in-depth modeling approach. And for the global level analysis, the group are at the initial phase of developing a global modeling platform that simulates the impact of cancer treatment disruptions. And this platform will use the international data on cancer treatment and survival, such as the SurfMark data that Isabel just presented, to inform the platform parameterizations and assumptions. The group is also planning to conduct a more in-depth analysis using the well-established microsimulation models of cancer natural history and screening. This work will involve further developing the existing microsimulation models to incorporate a more detailed cancer treatment pathway so that the model can then capture the joint effects of screening and treatment disruptions and can be used for a more in-depth analysis for specific countries and cancer type. Currently, the initial work is focused on colorectal cancer, and going forward, this work will involve the microsimulation modeling teams who are currently involved in Working Group 2. And we are very looking forward to establish connections with between Working Group 1 and 2 in this space. Thank you.
Thank you very much, Jabin. So that's the Working Group 1 update. And now we'll move on to updates from the different project teams in Working Group 2, but I'm going to ask Iris Lansdorp, one of the chairs of Working Group 2, to introduce this section. Over to you, Iris.
Thanks, Karen. Thank you very much for all being present during the call. I'm going to give you an update on Working Group 2, which deals with screening. We're going to focus actually on 3 projects from 3 different project teams from colorectal, cervical and breast cancer. But first, I'm going to give a short overview of the status of all project teams. So Working Group 2 currently exists of 5 different project teams, each focused on a different cancer, except for there's 2 for cervical cancer. So we have the colorectal cancer screening project team, which currently includes 39 collaborators. We have the breast cancer screening project team with 19 collaborators. And then for cervical, we have 2 project teams, one with a high income focus and one looking at cervical cancer elimination with a low and middle income country focus. The first one includes 22 collaborators and the second one 13 collaborators. And finally, there is a project team looking at delays to lung cancer screening implementation, which currently includes 10 collaborators, and that's still in the initial phase. And as you can see from the number of collaborators, it's very clear that why we had to split up in smaller teams to make this working group workable. So that's why we actually have several focus teams. And I would now like to ask Joa to give an update on the colorectal cancer screening project team.
Thanks, Iris. I'm Joel, come from Cancer Council New South Wales. So the colorectal cancer screening arm of Working Group 2, if we can go to the next slide, has looked at a range of hypothetical disruptions to the screening programs in 3 different countries during the COVID-19 pandemic. So Project 1 specifically has looked at just interruptions to screening programs. And we're doing a comparative modelling between the different screening programs and between different disruptions. I'll talk a bit about that in a minute. And Project 2 and 3, I believe, will be discussed by other groups, so I'll leave it to them to go over that. So if we can go to the next slide. Project 1 looked at these hypothetical disruptions, which evaluated 3, 6 and 12 month disruptions to cancer screening during 2020. These were all evaluated using microsimulation models from the Netherlands with the ASCA group and Miscan Colon, from Canada with OncoSim, and in Australia with Policy One Bow. In addition to pauses to screening, we also looked at reductions to screening participation in the wake of a pause to screening, either due to access to medical resources or behavioural changes, as well as the possibility of organising catch-up screening for people who missed screening due to these pauses. The policy message that's coming out of this is reasonably clear. Wherever possible, screening cannot be paused. The colorectal cancer deaths in many cases will outweigh any increase in deaths due to the dangers of screening. Where suspensions are necessary though, catch-up screening can do a lot to mitigate almost entirely these pauses to screening. And we have to keep in mind that for this project, all of these pauses are entirely hypothetical. Real world data is only starting to become available now, and that's something we'll be looking at in the future. But we've submitted a manuscript based on this work, led by Lucy, and that's currently under review at Lancet Gastroenterology and Hepatology. And I'll hand back to Iris.
Yes, Joanne, I immediately defer back to, I think either Francine or Veerle will do the first session today. So please go on to project 2.
Hi, I'm Francine from the Decision Modeling Center at the Amsterdam University Medical Center. And I will tell you about project 2, which concerns the optimal restart of colorectal cancer screening programs after the COVID-19 lockdown. And in this study, we will assess how the impact of the lockdown on colorectal cancer burden can be minimized while taking the limited colonoscopy capacity into account. And we have simulated scenarios that differ in the fit threshold that is used during the period after the lockdown, which we refer to as the recovery period. And we also consider different lengths of this period, in particular 6, 12, 24, and 36 months. As for project 1, we do the analysis with 4 microsimulations for 3 countries, so the Netherlands, Canada, and Australia.
Thanks, Francine, and thank you, Joa, for this excellent update. So as you can see, we are very excited about the 2 projects that we're currently working on, and just a few words on the 3rd project, where once the analysis for the 2nd project are done, we're going to start fleshing out the scenarios for the 3rd project, where we're really going to use existing data sources around the world to try and see what type of disruption, real world disruptions have actually occurred, what the colonoscopy capacity was after those disruptions, and what the impact, maybe that's most importantly, what the impact of the disruptions has been on participation during the period after disruptions, not just for participation with the primary screening test, but also with participation after with a diagnostic colonoscopy following a positive test. The other thing, the data that we're going to use will come from different countries, but one important data source will be the International Cancer Screening Network, where they already are conducting or have conducted a survey, and they are currently in the process of writing up the results of that survey on more the high overview level impacts of disruption. So how many programs were stopped, for how long were they stopped, when were they starting again, and what was the capacity when they were starting again. But there's also, as part of the colorectal cancer working group in the International Cancer Screening Network, there currently is a data tool or data collection tool being developed to really collect age-specific data on the impact of disruptions on participation after screening. So that data tells us how many invitations are being sent out after the disruptions, during disruptions, et cetera, so that we can really start modeling real-world scenarios, and we really have information from different countries in Europe and across the world that can provide the inputs that we need for our models. And with that, I would like to give the floor to the cervical cancer screening group.
Thank you, Iris. My name is Megan Smith, and I'm from Cancer Council New South Wales. And as you can see from this slide, here I co-chair the cervical screening in high-income countries group with Dr. Emily Berger and Dr. Alex Castanon. And as Iris mentioned, there's about 20 people who have showed interest in being involved. Roughly half of them join our regular calls. If you could go to the next slide, please, Karen. So for our first evaluation, we've significantly advanced a paper that's looking at the health outcomes of COVID-related delays to screening. And in this first analysis, we've assumed that delays to screening and potentially also follow-up services after an abnormal test is either 6 or 12 months in all settings, and that there's a quick recovery thereafter. So this paper is looking at how disruptions vary in the different settings, even when the disruptions are standardized, and how program characteristics, such as whether the screening is based on HPV or cytology testing, impact on the resilience of the program itself. We're also going to be looking at the age ranges most affected by disruptions and the resourcing implications of implementing a really quick recovery. And the idea is that the findings from this first paper on test capacity that's needed for rapid recovery and who is most affected by disruptions would inform our second paper, where we'll explore in detail the harms and benefits of prioritising different groups during the recovery period. And thank you. Now on to the next slide. So our analyses will be able to draw on a number of well-established simulation models of HPV vaccination and cervical screening across a range of countries. They include Policy 1 models from our group at Cancer Council New South Wales for 4 countries, MeScan models from the group at Erasmus Medical Centre for 3 different countries, and Harvard models for 2 different countries. We don't yet have results from all of these countries in our first analysis, but hope to include them in the future. Our group would like to work towards modelling scenarios using real-world data. At the moment, those data are very limited, and they're not completely informative because there is a lag in what's available, and the crisis is ongoing and still a very dynamic situation. We're also interested in modelling the role of new technologies in aiding recovery, including, for example, screening on a self-collected sample, because this could help address situations where primary care capacity is compromised. We'll also be participating in an upcoming meeting of the HPV Prevention Board that Karen mentioned earlier, discussing in more detail the anticipated delivery and supply side challenges in cervical cancer prevention and the data that would be required to inform modelling. And now back to, I think, is it Iris, or the breast screening update?
Yes, please go ahead with the breast screening update.
I can't see you all. I can see you all, but you probably can't see me. I'm in the dark here in Edinburgh. I'm Janine Figueroa. I'm co-chairing the breast screening project with Kaz from, I believe, Australia. So we had our first screening, breast screening meeting a couple of weeks ago, and we've had 18 people interested in this, and there's already a lot of work, and we have at least 6 models that are available to us. So our aims are to look at various different settings and document and estimate the disruption of breast screening due to COVID in various different countries, including Europe, US, obviously UK and Australia. Again, we have quite a few models already calibrated and validated that we can tap into. We are going to also be accumulating more data and real world data on actual referral and treatment service patterns, as has been already mentioned in many of the other groups. And of course, estimate the impact and cost effectiveness of catch-up, as has been kind of shown already in colorectal cancer and cervical cancer. Next slide, please. So yes, we're going to have our next meeting in a couple of weeks, and we're going to first consolidate the existing models and the outputs, because I think we already have a lot of data already to put our first paper together, and also accumulate key data sources from various country settings. One thing that we noted in our call that we're probably not as good on right now that would be great to get some input from the consortium is particularly middle and low income countries and models that might be useful to those settings. I know from our anecdotal work here in Scotland that we see, obviously not surprisingly, that symptomatic cases are where we're going to have the excess mortality. And it'd be really good to, I think, try and find some ways that could be and mitigation measures that could help reduce those excess mortalities in other income and low middle income countries. So if you weren't a part of our first call but are interested in contributing to the efforts, please just let us know, and we'll be meeting again on Wednesday, the 25th of November. Cheers.
Thank you very much, Iris, and to all who've been involved in the screening work. That's a range of very exciting updates, and I really am particularly excited to note, the focus on what you might call the silver lining, the risk-based approach that's being in effect fast track evaluated with colorectal cancer, with the idea of actually prioritising according to the information in the FIT test itself and changing the threshold, and maybe the silver linings in cervical cancer screening from fast tracking HPV self-collection, for example. So I think those are really important evaluations for countries that are ongoing. So we'll now move to Working Group 3, Prevention, and I'm going to ask Dr. Peter Saric to give an overview of the activities so far in Working Group 3. Thanks, Peter.
Thanks, Karen. So yeah, today I'll be giving an update for Working Group 3. So this group is jointly led by Dr. Ophira Ginsberg, Dr. Isabel Sojama-Taram, and Karen Canthal. And the co-leads are currently in the process of setting up a smaller focused working group for planning and priority setting of research questions for the Working Group 3 and potential data sources, and also a protocol for a systematic review investigating smoking behaviour changes during the pandemic has now been lodged on Prospero. And we are also planning a call for surveys on COVID-related behaviour changes, which I'll come to later. So next slide, please. To assess the impact of the pandemic on long-term cancer risks, we are undertaking a systematic review looking at whether COVID-19 is associated with changes in tobacco smoking behaviour. And we've noted that reviews by others of the possible impacts of alcohol intake, obesity and physical activity have already been registered on Prospero. Next slide, please. So our systematic review covers the published academic literature and preprints as of September 23 this year. And we are now up to the data extraction phase, and we expect that around 30 studies will be ultimately included. And the 4 people who are performing the data extraction are Citadel Kabasag, Erica Lieberman, myself, and Pavlo Vanichka. And some preliminary results are that almost all of the included studies are cross-sectional studies of self-reported changes. Along with it, there's a few before and after studies. The majority of studies relied on convenient sampling rather than representative sampling. And also there's a lot of variety in outcomes, so ranging from smoking prevalence, increases and decreases in smoking intensity, quitting, initiation and reinitiation in ex-smokers. So a lot of variety in outcomes. Next slide, please. So many of the large-scale representative surveys of smoking and other lifestyle cancer risk factors are undertaken by government or health organisations. The results of these are often published in online reports rather than in the academic literature, and they are not covered by existing grey literature search methods. So as the information from such large-scale surveys is very valuable, we'd like to include it in our future assessment of how behaviour changes during the pandemic will affect long-term cancer risks. Next slide, please. So we're planning a separate piece of work which will bring together the evidence on behaviour changes, including smoking and other cancer risk factors during the pandemic, from large surveys carried out by national or local governments, health organisations or other bodies. And we also plan to consider targeted surveys that ask explicitly about behaviour changes during the pandemic, as well as any regular surveys or cohort studies that would have information on behaviour before and during the pandemic, so we can assess any differences. So as a first step, we're carrying out a wider consultation and would very much appreciate input from the wider group, especially Working Group 3 members. So we'll be sending all Working Group 3 members a link to the form asking for information about any relevant surveys in different countries and jurisdictions that you're aware of. And it would be a great help if you could complete this in the next week, but we'll also keep the survey online. So please add information on further surveys you become aware of at any point in the future. And next slide, please. So here's what the online submission form looks like. It should only take about 5 minutes. So I'll just post a link on the Teams chat now, and the link will also be available in the upcoming minutes and newsletter after this meeting. So here is the link. And we also asked, could you please circulate this link widely with your networks as well? Thank you.
Thank you very much, Peter. And yes, that's one of the opportunities to get involved by helping put the team in touch with any country level activities on surveys of smoking, or indeed potentially other behavioural changes relevant to long-term cancer risk. I'm just going to cover the next piece very briefly on behalf of Dr. Rami Rahal, who is one of the steering group members and is from the Canadian Partnership Against Cancer. Rami and many of our North American colleagues will actually be joining us on the next call rather than this call. I think it's in the middle of the night, but Rami will be helping to lead a planning process that we want to launch today on planning for dissemination of the findings of the consortium. So what we wanted to do today is really call for expressions of interest. If those of you on the call are interested in being part of this planning group and contributing to this broader discussion of dissemination of our findings, please let the Secretariat know. Just briefly, a couple of the ideas that have been put up so far for dissemination of our findings for the strategy. Firstly, we'll be looking at setting up a broader community of practice around the dissemination of the findings. The idea here would be that we would involve a wider group of modelers. Obviously, we would start with you as the consortium members, but we would look to set up a community of practice to work with clinicians and policymakers to take our detailed findings, some of which you've been seeing today, and turn them into rapid, actionable pieces of information that can be used to support policy making and inform best cancer control practices for different jurisdictions as we go forward in the light of current and unfortunately potentially future waves of the pandemic. Obviously, we're already starting to see that translation into the scientific literature and CC GMC members presenting at key scientific meetings, which is fantastic. And we also, through the community practice, will look to potentially develop dissemination mechanisms such as policy briefs for decision makers. So again, if you're interested in contributing to this process and being part of that knowledge dissemination working group, please let the Secretariat know. So it remains with me to just give you a brief update on the plans for the next call. What we have discussed is that we are looking to organise the next call around February, March next year. Clearly, it's not clear where we'll be in terms of pandemic evolution, but I guess what we can say is that we do expect that some of the results that you've seen in process today will be coming through. We should have results from the systematic reviews that are going on for COVID and cancer and for smoking behaviour. We should have more modelling results from the cancer outcomes and treatment side of things. And obviously the screening project teams will be generating further results as we go forward as well. So that's our plan there. And I think we're now 10 minutes ahead of the game. So we do have we have 10 minutes for discussion. So please, if you would like to contribute to the discussion, Freddie and I will moderate, but please log questions or comments in the chat and we'll open that up for thoughts. Thank you.
Okay, Karen, there's no, at the current time, there's no messages in the chat other than Peter's survey link. But just while people are collecting their thoughts, just to thank everyone on the call. I thank the presenters in particular from the task force chair, Richard, through to the working group chairs and all the presenters. I mean, you've seen an incredible amount of work in a short space of time. So I'm hoping that the lack of questions is the reason is people intensively listening and trying to better understand where we are and trying to encapsulate the questions. But we've got 5 or so minutes left. So if there are any questions, raise your hand, or I guess you can just speak as well, and we'll be silent for a minute to see if there's any questions. people are overwhelmed. Karen, here we go. Here's one. Just this is from Sylvia to San Jose. Thanks for the work. Can you update on cervical cancer screening in low medium income countries? Karen, is that one for you?
Yes. Thank you, Sylvia. So, so we are our key step here, we think, is the discussion that will be facilitated by the HPV Prevention and Control Board, which is unfortunately, it's an invitation-only meeting. But having said that, if consortium members are interested in participating, please let the Secretariat know. It is a meeting that does manage to gather really the world experts in HPV prevention and control. And so we have a session that we're running in partnership with that group. And the aim of that session is very much to present some of the initial findings from the consortium and to run a panel where we will really seek the views of the expert community on the important questions and the important issues and challenges for modelling. And the impact on cervical cancer elimination will be a key part of that. So I think, Sylvia, it's obviously a rapidly evolving discussion. Some initial modelling has been done. We're not quite ready to present it, but we're hoping to present it in mid-November to that group to inform that discussion. I think the focus will be on whether the timeline for scaling up to the elimination targets, which for those that aren't close to it, WHO has set 2030 scale up targets for vaccination, cervical screening and treatment, and scale up of cancer treatment services to very high levels by 2030. WHO will be formally launching their elimination strategy also in the next couple of weeks. And I think the hope of the community is that a disruption because of COVID, which we certainly have already seen in 2020, we've seen many school-based vaccination programs pause, for example. We've seen screening programs pause, and we've seen a delay in implementation of elimination in low and middle income countries. But it's a hope that, if concerted efforts are made, that recovery would be able to scale up in time to meet some of the, or at least come close to the 2030 targets, and modelling will be informative in what recovery strategies will be most useful. So that's a long-winded way of saying it's work in progress. We're hoping to involve the original modelling consortium that helped WHO in their formulation of that strategy, Sylvia, and we encourage all of you who are particularly interested to get in touch and register for that special meeting on that topic. Sylvia, happy to hear from you directly on your thoughts on that, though.
Yeah, thank you, Karen. It's difficult to see the different angles, with all this now second wave that is affecting the high-income countries, how this is going to affect as well low middle-income countries, where now they were starting to start again with the screening. So very complex situation, and we work closely to follow up, to meet at least some strategies for control.
Yeah, indeed, indeed. Thanks, Sylvia.
Yeah, just a few more chat questions and comments. I'll just relay to the group and to you, to Karen and everyone else. One from Joanne Aiken. Thanks to all speakers, amazing work. Thanks, Joanne. And we are working, as you know, on the cancer registry impact as well of COVID with Isabel Segeramataram. So that work's ongoing as part of the task force, but we hope to share it also within the modelling consortium as well. I mean, it's really important to see what the impact on cancer registries worldwide is, and Joanne is the president of the International Association of Cancer Registries. One from Kota Katanoda in Japan. We have done an internet survey on the effect of COVID-19, including behavioural changes in smoking and screening, and just going to register that, which is great. And then just a couple of questions. One from Iris, actually, to Isabel. I guess Isabel Segeramataram. how will you disentangle the impact of comorbidity for not being treated from the result of delays? Isabel, are you able to answer that in 30 seconds?
So very quickly, in the data sets, we have then a few countries that sent us comorbidity data, at least then before the COVID. So we'll see whether then we can use any of that information. And then again, afterwards, we need then to combine it with available literatures that we're doing a lot of reviews on, and hopefully later on with also real data.
Mm-hmm. Okay, thanks very much. And then the last question I have is from Martin Uzerman. Great updates, thanks everyone. Are there initiatives for data sharing and cross-validation of diagnostic treatment delay models? Many presenters proposed using real-world data, and some countries probably are ahead of others. Any comments on that, Karen?
Yeah, great question. Thanks, Martin. So I guess the short answer is yes, but we're at different stages. I mean, you've seen, I think we're at we're in a good place from the point of view of the screening group collaborations and data sharing there. And many of the consortium members who've joined those groups are actually representing screening programs in different countries and able to bring in data sets. And that's a very active discussion in the screening space. And as Iris referred to, I mean, there's also central surveys like the one that ICSN is running. I think from the cancer, from the diagnostic delays outside of the screening environment and the treatment delays, I think that's a process that we're trying to initiate now. So again, if people are interested in helping being part of that, we're looking through Working Group 1 to convene a group to really talk more about the data sharing aspect of that, particularly as we're seeing these important systematic reviews coming through that you heard about. That's coming, the one coming out in BMJ this week, and the data from Isabel and the IARC team. So I think that's going to be an important ongoing discussion. Please do let us know if you'd like to be part of it. Thanks.
Thank you, Karen. I don't think we have any more questions from the chat box, and there's no raised hands at the present time, Karen, so I can allow you to close the meeting if you like, 1 minute ahead of time. You're on mute, Karen. You're muted, Karen.
Sorry. Thank you very much to all the presenters. It's just fantastic, the depth of information that was presented, and to all of you, thank you very much for letting us move so quickly through this. I know that there may be many questions, but we just wanted to make sure you had an update of the breadth of the activity that's going on. So again, let us know if there are issues you would like to see more focus or depth on. Contact the Secretariat, and we look forward to you continuing the activities through the working groups, and hope to see you again in a few months' time with another range of results. Thank you very much. Thanks, Freddie, as well.
Yeah, thanks, Karen. Thanks, everyone.
Thanks.
Bye-bye.
Bye, everybody.
Thank you.